Welcome back to RhAPPcast, the official podcast of rheumatology advanced practice providers. I'm your host, Amanda Mixon, and today we're diving into a condition that sits at the intersection of multiple specialties and often eludes early recognition, hypophosphatasia, or HPP. This episode, Diagnostic Crossroads, Clues, Pitfalls, and the Journey to an HPP diagnosis, is all about sharpening our clinical lens. We'll explore the red flags, subtle presentations, and common missteps that contribute to diagnostic delays, and the real-world burden that imposes on patients and families. Our goal today is to better understand the biology and spectrum of HPP, appreciate its impact across lifespan, and highlight the clinical reasoning that leads to an accurate diagnosis. I'm thrilled to be joined by Wendy Simmons, a respected colleague and valued member of the RhAPP board and community. Wendy brings deep experience in evaluating complex musculoskeletal presentations and will help us unpack the diagnostic challenges that make HPP such a fascinating and often misunderstood condition. Wendy, welcome so much back to RhAPPcast. We're excited to have you.
Amanda, thank you so much. I was always excited to be here and really feel that those key words and that wonderful introduction with this rare genetic disorder. And it's fantastic to be able to be educated about it, as there's a huge need as well.
You know, it's interesting because, a little more about Wendy. She really is an osteoporosis guru. I have been doing healthy a long time, but actually find osteoporosis and these types of things somewhat challenging or very challenging, as Wendy knows. I'm often reaching out to her to ask her questions. And so I know that this episode is going to be really impactful because prior to learning about this, which was not that long ago, I think I've been probably missing it.
Exactly, Amanda. And I will never consider myself the ultimate guru because it's so easy to potentially miss this genetic disorder, as it is rare, however, so important to be educated on it, to be able to catch that. No matter how many thousands of patients you see, or I would see in osteoporosis and disease state, we all are seeing patients, I'm sure, with, as we'll see throughout this program, some of the signs and symptoms and disease states we treat that these patients could potentially have HPP.
Absolutely. Well, let's go ahead and get started so that our listeners can understand exactly what it is. So, can you walk us through how you define hypophosphatasia in terms of its underlying biology and what makes it distinct from other metabolic bone diseases?
Absolutely. As we have mentioned, HPP is a rare genetic disorder, and this is characterized with a low alkaline phosphatase. That's to be remembered, and with this low alkaline phosphatase, that then would lead to poor bone mineralization. So you're really not getting that deposition of the calcium and the phosphatase in that bone to have it be strong. This is caused by genetic mutations, of which there's 400. And this genetic mutation is ALPL gene. And then that therefore leads to a deficiency in an enzyme tissue nonspecific alkaline phosphatase. No, that's a long word, but this is referred to as TNSALP. In turn, you're not having that mineralization of the bone, as I mentioned. And this makes soft bones, this makes soft teeth, and then by failing to break down another substance, which is an inorganic pyrophosphate referred to as PPI, this is a substance that would inhibit the process. So it's metabolic. Low alkaline phosphatase is key here for us as we're thinking, oh my goodness, I'm working in community clinic, I'm working in academic, I'm seeing all these patients. Low alkaline phosphatase is really what's going to help us here as well. This enzyme tissue nonspecific alkaline phosphatase can also decrease peroxidal 5-phosphate, and it will build up, and that's important as well. So keys, alkaline phosphatase, your calcium levels as well. The severity of this genetic disorder can equal the amount of mutations as well. And just to really add in here, which I really think is important for our platform to understand what we're really talking about today, there can be 6 forms of this. I don't want everybody to feel like this starts in adults. This starts in our peds division. Would love to have a peds person with me because it would be interesting to see how this can evolve. But the 6 forms, the one starts in the perinatal period, and that perinatal period can be lethal. Then into prenatal, infantile, childhood, adult. And in the infantile and childhood area of this disease, that's where often skeletal deformities are seen with short limbs. Those children can have respiratory failure. So that's very important. I'm not speaking for a peds person because that's just not my area, but just to mention that we have to be cognizant of this. And as we go through this program today, we'll see why it's important to pay attention to the childhood. As we get into adult, it could be certainly mild. Often we see premature loss of baby teeth. The roots stay in the gum. That leads to our 6th form, which is odoto hypophosphatasia. So it's really, really interesting. It's very fascinating as well. We have to separate this from other metabolic disease states that potentially could be causing hypophosphatasia. Our phosphates are regulated. We look at hyperparathyroidism, can be regulated by PTHs, 1,25-dihydroxy vitamin D levels. And then there's also fibroblast growth factor 23 that's important. So we can lose our phosphate by not absorbing it, or it's getting excreted, or it's going extracellularly into intracellularly. That's a lot of underlying biology there, but I think it's just really important to emphasize that really the balances of the phosphate and calcium and metabolically how that is seen in the body.
So, how do people present? Like, what are the key signs, symptoms that we should be thinking about if we see a patient? I mean, obviously, you kind of mentioned the low
Yeah.
alk phos, but can you expand upon that a little bit?
Yeah. So this, certainly rheumatology, we're going to see, one side of this. This crosses many body systems as you've mentioned. So these people could have been, with ortho, endo, PTOT, presenting could be very mild. These patients could have been diagnosed with osteoarthritis, fibromyalgia. Primarily what we see in rheumatology to figure out the musculoskeletal pain, joint stiffness. Often a little key here, I feel that to find something different would be pain in the long bones as well. Certainly fatigue, headaches, there's neuro symptoms. Patients could have had a history of seizures, neuropathies, as well, confusion. Some of our patients we see that have CPPD, calcium deposition disorders, that might be a little clue. If you're seeing one of those type patients, you might want to think about working that up. People with microfractures, pseudo fractures, stress fractures. Now they could be as easy as that maybe, but there can be atypical femur fractures. I've got a lady now I'm actually working up for this that she's presented with atypical femur fracture. And yes, she does have osteoporosis. However, she had never been on a bisphosphonate. And, you have to think of where that fracture could come from. So really a whole lot of cross multi-specialty, many body systems. If you are working up osteoporosis, it's important to be checking those PTH levels, alkaline phos levels if you can as well.
What do you feel like are some diagnostic pitfalls when patients with HPP first present? I think I kind of know the answer because of what you just said, but
yeah, I mean, this does certainly all cross in together, and I think we'll see that, in the end, really the specific things we have to pay attention to. Really, this disease can present with many of these unspecific symptoms. We can miss those. That certainly could be a pitfall. We just don't we have a lack of awareness. So we definitely welcome education, refresh. You might be reviewing some labs You might notice some low alkaline phosphatase. A lot of times I feel that when you're doing an osteoporosis evaluation, you're thinking of looking for a high alkaline phosphatase, right? With, bone breakdown or, that part of the metabolic process. But you start seeing low alkaline phos, it's not like, oh yeah, this is great. You should be thinking, I probably should think about why this is low and working that up. Certainly, I think, we need to be thinking about, we do great family histories, but maybe in adult rheumatology, we're specifically paying more attention to that adult history. I think childhood histories are really important as well. What were any growth issues, what was your childhood like? Did you go to the doctor? Did you have bone pain? I think those are good to pay attention to as well. I know we have some of those patients that will present to us. They'll say, I've hurt all my life. Dental histories are key here as well. I feel that if I had to put the top two not to miss would be, looking at some labs with low alkaline phos and getting that history with dental. Did you keep your baby teeth very long? I always remember I was teased for keeping mine too long, but some people certainly lost them much earlier, and that would be key as well.
Wow, this is so helpful to me because I'll tell you, like, I see some of these low elk phos levels and, don't exactly know why, don't really know what to do about it. I often tell people to go back
Right.
to their primary care and,
Yeah.
but really, we should be the ones, or maybe endo to really work this up. So, talk to me about the burden of disease for the patient. Like, how does that extend beyond the skeleton?
Absolutely. A quality of life is we recognize in rheumatology across all our disease states as well. These patients obviously can hurt. They have pain. We don't want to always discount that. Muscle weakness really is another symptom there on that list. If you took it down into the peds division, into the infantile, knowing again that this is a genetic disorder. That term floppy baby you might have heard of, that certainly can be representative of this, into adulthood, muscle weakness. These symptoms, this disease is one that we know is missed, is I'd rather refer to it as not picked up quickly. So these symptoms really can build over time. So digging into that history, muscle weakness, neuro symptoms, confusion, have they had a history of seizures? Breathing, cardiac, that might be more in peds as well. Maybe some hemolysis or platelet dysfunctions you would pick up as well. Walking growth, children will waddle rather than walk. So again, just leading back to investigating. But as you can see, once you have these symptoms or changes have occurred in the skeleton or even extraskeleton symptoms, that can lead to poor quality of life in these patients.
Right. So it sounds like, again, it's a whole host of things, but from what you're telling me, it can be something, obviously, if it's a child that's like, breaking bones or, these kinds of things. But it sounds like, again, why it's often missed is because maybe sometimes it's not quite as obvious. And then they get to adulthood and then they come to us and then we might thinking it's fibromyalgia or, something like that. But it sounds like we really should have this at least as part of our differential when we're seeing these patients.
Yes, I feel that way as well.
Talk to me a little bit about labs. What role do abnormalities in standard labs, such as again the alkaline phosphatase or phosphate, play? Or how does that play in alerting clinicians to HPP? And how might these clues be overlooked? I have to tell you, I've probably overlooked it, so this is super helpful for me.
Well, and it might not always be necessarily something that you've overlooked. I think really one of the main points on the top of the list is that the serum phosphate levels as well are not usually on all our panels.
Yeah.
So they're not always standard. I know the panels that I get, with the workups for osteoporosis at least, but this doesn't include all my other patients are paired, PTH, and that does include my phosphate on there. So I have a couple of people right now that have real low phosphatase levels, so I can look into that. Getting, it's on my comprehensive. The alkaline phos is on the comprehensive. Patients very often we pick up have hyperparathyroidism. Calcium's elevated, PTH is elevated, vitamin D's can be low. You might also certainly check with your endocrinologist. There can be renal issues. We talked about excretion of phosphatase, magnesium deficiencies. These can also represent, these abnormal labs can represent other metabolic concerns. And so there is a little bit of astuteness to be able to, get that history and really put everything together as well. I did mention that FGF23, the fibroblast growth factor, it's not really truly active out there right now for a lab test. I don't know if peds are getting those. I wouldn't be recommending just, getting those. I really think a lot combining your history and your labs. If you just maybe get to know your lab a little bit better and figure out where that serum phosphate level might be landing as well, correct your vitamin D deficiencies, certainly, which will help as well. And work up your patient. One thing I did fail to mention that I just remembered, in those patients presenting across our path, we could be seeing these patients in another disease state. I actually learned an interesting fact that there's just a little over 28% of psoriatic arthritis patients that actually have HPP. Seems like a lot. I mean, I did read this in an article, patients that are failing DMARD therapy, because, and you think about this, and just to give a little point out here, this disease can actually cause enthesopathy, calcium deposits around the enthesis. Really makes sense. We see patients that come to our practices from other areas, and they, maybe they could have both, but that's just a little clue there as well for your early ID, trying to identify and treat and manage these patients. Just one more point. I have an osteoarthritis patient, and she has bow legs, and she's an adult. And she said this, I was told it's from my osteoarthritis of my knees. And I started to think, well, if all of these patients that have osteoarthritis of bilateral knees were bow-legged, we would have a different looking community. So just really trying to think about tying our labs. They are a diagnostic tool. We're looking specifically for that alkaline phos to be low. But those abnormalities are definitely important.
So, I want to try to give the bigger view here, right? So as a rheumatology provider, obviously you've mentioned some of these key like red flags that we really should be thinking about. But can you just reiterate that? And then I guess the other part to
Yes.
this is so we see a low alk phos level. What do we do?
See a low alkaline phos level. You want to go ahead and be sure that you are following through with other labs, PTH level, vitamin D level. And I would jump into history, look at fracture history, look at bone pain. Have you had fractures? What type of fractures? Have you been, told you had osteoarthritis? Where's your bone pain? And go into our regular histories of, joint stiffness, mobility, dental. I really feel that there are keys. I have osteoporosis patients that will say, I've come to me and they've been on therapies, and they'll say, this therapy, I'm not taking anymore because it caused my teeth to break. That's not osteoporosis with the teeth breaking. So I think it will lead you to other things. But low alkaline phos, certainly repeat that, and then go dive into your PTH, phosphatase levels, calcium and D. And for a long time, I was getting vitamin D 125 dihydroxy levels. That's really more the storage of the vitamin D, or contact your endocrinology division. You could do renal studies, you could do urines.
Again, kind of, I think you're making the point that we really have to have good cross collaboration, with our endo colleagues, maybe our ortho colleagues, all of those things. This is super helpful because again, I have to say I run into these low alk phos levels, and sometimes I really don't know what to do. And really, I think I should know what to do, and I should be able to order the correct test. And maybe from there, they do need to see an endocrinologist, but at least helping determine why, because again, I think that's what's important. Probably these people have been suffering for a long time, and maybe just didn't get the right diagnosis,
Right. And I know that we're taught also, I think the easiest things that we're all busy, specialists are all busy, and, one lab that's abnormal. I know even sometimes my PTHs, if I get them to endocrinology, like, oh, I'm not going to worry about it. Different areas, even in endocrinology, have different interests as well. We're always, as we do, if we have a normal lab test, repeating that. Certainly, over time as well, I think is really important. These labs can fluctuate. Certainly. So repeating them, I think, is very helpful. But the real patients that you potentially can pick up with a milder form of HPP certainly could have some of those milder symptoms and would potentially warrant maybe some genetic testing, which I'm sure you can get through your lab. And as you talk with that patient, they would be willing to look into that further.
So just one last question for you. So looking ahead, what areas of disease burden and awareness in HPP still need more attention among rheumatology teams to help shorten diagnostic delays and reduce the kind of downstream impacts that obviously can happen?
Even myself, Amanda, I've looked at this education. I really feel that, and I'm so happy that you're doing this podcast as well, because it leads to more reading. And I really would recommend everybody, even after this podcast, if you had the opportunity to get a little bit more education on this as well, refreshing. Even if you know about this disease, I feel comfortable about it. Even myself, refresh. I hope
think
that
that's
we get to see some more education with this. Absolutely.
Thank you so much. And again, I'll share your personal cell phone with everybody so that they can
Bring it on. I love to teach. If I can help a patient through a colleague, I love to do that. As you know, I just really think that we do a great job educating each other. And you never know. I know that after this podcast, if a patient like this comes across our path, we're going to be thinking about it as well.
Absolutely. And that's, I think,
And certainly be fun at another time as well to hear from our peds colleagues and see what that does look like in their world. And I think it would be maybe a sadder case. I don't know what the severity is as well, but certainly we don't want all these patients fracturing.
Yeah, absolutely. And, again, I think if you do have more questions about this, it's a good opportunity to come to one of our RhAPP, meetings, come for one of our annual meetings, because Wendy always does such a great job kind of helping with the osteoporosis aspect of it. And again, I'm so fortunate to have you personally, because I do send you a lot of messages about my osteoporosis patient. So I really appreciate that.
Thank you so much, Amanda.
Well, thank you again for joining us for another episode of RhAPPcast. We hope today's discussion shed light on the diagnostic complexities of hypophosphatasia, and in many ways, its signs and symptoms that can be overlooked or attributed to more common conditions. Improving awareness of this disease state really can help us understand how to make this diagnosis and ultimately really helping our patients. A huge thank you to Wendy Simmons for sharing her insights and experience with us. And thank you to our listeners for your continued commitment to clinical curiosity, diagnostic excellence, and elevating the standard of rheumatology care. If you enjoyed this conversation, please be sure to tune in for future episodes of RhAPPcast, where we continue exploring the science, challenges, and evolving understandings of rheumatic and musculoskeletal disease. You can find all of RhAPP's digital education in our content room at rhap.org, or RhAPP ACE 2.0 mobile app, and of course on our podcast RhAPPcast. Thank you. Until next time, this is Amanda Mixon.